Hello everybody, this lecture will be covering the axilla and brachial plexus. Let's go ahead and start by defining the axilla, and the axilla is this pyramidal shape inferior to the glenohumeral joint, and the axilla is going to provide passageway for the neurovascular structures that are servicing the upper extremity. Now the shape and size of the axilla can vary depending on what position the arm is in. Is it abducted? Is it adducted? But the axilla is going to have an apex or cervical axillary canal, a base, and 4 walls, 3 of which are muscular. So let's take a look at the shape of the axilla and what makes up the apex, base, and 4 walls. Now we can see this nice beautiful schematic of the axilla and talk about these different components and the boundaries that form them. So starting with the apex, and the apex is going to be the passageway between the neck and the axilla, and the boundaries of the apex are formed by the clavicle, the first rib, and the superior border of the scapula. Now, if we go down to the base, shown here in yellow, the base is created by the concave skin, the subcutaneous tissue, and the deep axillary fascia that extends from the arm over to the thoracic wall around the level of the 4th rib. Going to the medial wall of the axilla, we can see here in purple, and the medial wall is around from ribs 1 to ribs 4. And this includes also the musculature, so our intercostal muscles, as well as serratus anterior, which is lying superficial to them. Going over to the lateral wall, this is going to be the narrow wall of the axilla, and it is right around the intertubercular sulcus or groove of the humerus. Now, if we think about some muscles that insert there are 3 that we've learned already. And 2 of them are going to help form the posterior wall. So the posterior wall, which we can see in red, is composed by the anterior surface of the scapula and subscapularis, which resides or originates in the subscapular fossa. But then recall we have these muscles coming from the back, going to the intertubercular groove or sulcus of the humerus. So latissimus dorsi and teres major. And then lastly, we have our anterior wall, which we can see shown outlined by the dashed black line. And this is going to be created by pectoralis major and minor, and the fascia that's associated with those muscles. Moving on to the vasculature within the axilla, very appropriately named, we have the axillary artery. So the axillary artery is the distal continuation of the subclavian artery. So once the subclavian artery, which we can see here, passes the lateral border of the first rib, it's going to change names and become the axillary artery. And it's going to be the axillary artery until it gets to the inferior border of teres major. After or distal to the inferior border of teres major, it's going to change names again and become the brachial artery. Now, the axillary artery can be divided into 3 parts, and those 3 parts are going to be relative to the position of pectoralis minor. Taking a closer look at our axillary artery, now we can see the 3 different parts of axillary artery. And again, we're going to use pectoralis minor to differentiate these parts. So from the lateral border of the first rib, where subclavian becomes axillary, to the medial border of pectoralis minor, is the first part of the axillary artery. And from the first part of the axillary artery, we're going to get 1 arterial branch, which is the superior thoracic artery. Superior thoracic is going to supply the first and second intercostal muscle, as well as the superior fibers of serratus anterior. Posterior to pectoralis minor, we have our second part of the axillary artery. And from the second part, we have two branches. So thoracoacromial, which is a trunk, so it's going to be a short artery that's going to sort of explode right away into four branches that are named for the areas they're supplying: clavicular, deltoid, acromial, and pectoral. And our lateral thoracic. So our lateral thoracic artery is going to supply the pectoralis muscles as well as the more inferior fibers of serratus anterior and some of the intercostal muscles. Now, distal to the lateral border of pectoralis minor to the inferior border of teres major is going to be the third part of the axillary artery. And just like part 1 had one branch, part 2 had two branches, part 3 has three branches. So we get the anterior and posterior circumflex humeral artery. So we have already looked at posterior circumflex humeral artery. And we looked at it as it was passing through the quadrangular space with what nerve? The axillary nerve. Okay, so now we can see that coming off, and we see it forming an anastomosis with one of the other three branches from the third part of axillary artery, which is the anterior circumflex humeral artery. So those are going to encircle the surgical neck of the humerus. And then our third branch is the subscapular artery, which subscapular is then going to give rise to circumflex scapular, which we can start to see right here. But if we look, now we can see circumflex scapular coming to supply musculature on the dorsum of the scapula. And so subscapular gives rise to circumflex scapular and thoracodorsal. And thoracodorsal artery is servicing latissimus dorsi, and it can be seen running with the thoracodorsal nerve, which is providing somatic motor innervation to latissimus dorsi as well. Venous drainage in the axilla is going to be very similar. So we have the axillary vein, and we're just moving in the opposite direction because we're talking about deoxygenated blood moving back up towards the heart. So the axillary vein is formed by the union of the brachial veins and basilic vein at the inferior border of teres major. So now we're going to see the formation of the axillary vein, and it's going to remain the axillary vein until the lateral border of the first rib, where it will become the subclavian vein. In the image, we can see the venous drainage. So we have our brachial veins, basilic vein, becoming the axillary vein at the inferior border of teres major, and then becoming the subclavian vein at the lateral border of the first rib. The lymph nodes of the axilla are arranged in 5 principal groups. The pectoral nodes are located along the medial wall of the axilla. The subscapular nodes are located along the posterior wall of the axilla. And the lateral nodes are located along the lateral wall of the axilla. And efferent or outgoing lymphatic vessels from these 3 groups pass to the central axillary nodes. And the central axillary nodes are located deep to pectoralis minor towards the base of the axilla. And the central axillary nodes then drain to the apical axillary nodes located at the apex of the axilla. So the apical group receives lymph from all other groups of the axillary lymph nodes. We're now going to move into the brachial plexus, but before doing so, let's just remember that anatomy doesn't have to be hard. There are ways to make life easier when learning anatomy. So the upper extremity is very organized, and we can divide the upper extremity into different compartments. And these compartments generally share a developmental history, and therefore they have a similar function. They also, within the compartment, have a pattern of innervation. So for example, if we're talking about the anterior arm, all of the muscles in the anterior arm are innervated by musculocutaneous. So instead of having to memorize biceps, musculocutaneous, coracobrachialis, musculocutaneous, right? If we know that the anterior compartment of the arm, all of the muscles are innervated by musculocutaneous nerve. If we think about the posterior compartment of the arm, well, this is really nice because the posterior compartment of the arm and the posterior compartment of the forearm, all of these muscles are innervated by the radial nerve. Okay, so again, it is a way to understand holistically what's going on without having to memorize a bunch of information. And as we move through the extremity, we'll see the same thing with the actions of these muscles. Moving into the brachial plexus now, brachial plexus is going to be responsible for innervation of all of the muscles within the upper extremity, some of the muscles within the shoulder, muscles of the chest, and we're going to see the formation of the brachial plexus, and it starts in the neck and extends into the axilla. And the origin, the starting point, are called the roots of the brachial plexus. So these roots are going to merge together, and then they're going to divide and come together and divide again. So while we're up in the neck, the brachial plexus is going to start with the union of the ventral rami of the C5 to T1 ventral rami. Let's go ahead and dive right into brachial plexus now. So what do we already know about brachial plexus? Just from a couple slides. We know that it's located in the axilla. We know that it's going to start in the neck and go into the axilla. So starting in the neck, we have the roots, and the roots are the ventral rami of C5 to T1. We also know that the brachial plexus is going to innervate muscles of the chest, of the shoulder, and all the muscles of the upper extremity. So if we go look at the picture, we can see the roots. So, right, we have the ventral rami of C5, C6, C7, C8, and T1. Now these roots are going to merge to form trunks, and the trunks are named for their anatomical location. We have the superior trunk, middle trunk, and inferior trunk. The trunks then divide, and they're just dividing to go anterior, posterior. So we have anterior division, posterior division, anterior division, posterior division, anterior division, posterior division. And then we're going to get the formation of the cords. So the cords, now how do we name the cords? The cords are named for their anatomic location relative to the axillary artery. So lateral to the axillary artery is going to be the lateral cord. Posterior to the axillary artery is going to be the posterior cord. And medial to the axillary artery is going to be the medial cord. And then the cords will give us our terminal branches. Okay, so the branches then, we can say to remember marmu, which is giving us musculocutaneous, axillary nerve, radial nerve, median nerve, and ulnar nerve. Now, of course, we have some additional nerves that we will go through as we start going through this, but this is here our core skeleton of the brachial plexus. Now, if we look at up back the supraclavicular branches of the brachial plexus, we can see coming from the ventral rami of C5, our dorsal scapular nerve, which we learned when we were looking at the shoulder. All right, so we have the dorsal scapular nerve we see here running with the dorsal scapular artery, and this is providing somatic motor innervation to levator scapulae, rhomboid minor, and rhomboid major. Then we can also see our suprascapular nerve, which we've already looked, and let's review. We have the suprascapular nerve going under the transverse scapular ligament, providing somatic motor innervation to supraspinatus and infraspinatus. And this is running with the suprascapular artery. So recall that the suprascapular artery goes over the transverse scapular ligament, right? The navy goes under, the army goes over. Nerve under, army over, artery over, nerve under. Okay, so we have the suprascapular nerve and artery. Then we can also see from C5, C6, and C7 the formation of long thoracic. And recall that the long thoracic nerve innervates serratus anterior. And then here we can see a little nerve that is going to subclavius, and its name is very straightforward. It's the nerve to subclavius. It's going to innervate the subclavius muscle. Okay, so we will look at the other branches that we see, the infraclavicular branches of the brachial plexus, but for now, let's start with these. So reviewing these supraclavicular branches of the brachial plexus, we have the dorsal scapular nerve. Okay, so dorsal scapular nerve, again, is going to innervate three muscles: levator scapulae, rhomboid major, and rhomboid minor. Then we have our long thoracic. This was coming from C5, C6, C7, and it's going to be responsible for innervation of serratus anterior. Nerve to subclavius, right, is going to innervate subclavius. And the suprascapular nerve. Suprascapular is going to be responsible for supraspinatus and infraspinatus. Repetition is key, so one more time with our supraclavicular branches of the brachial plexus, we can identify a number of things here, most of which we've seen in the lab. So a good landmark in the lab is the spine of the scapula, because we can see that nice ridge of bone, and it's a really good landmark to identify the surrounding structures. So we have our scapular spine, then we can see over here inserting on the root of the scapular our levator scapulae muscle. And of course we have our rhomboids, so minor over major. We have rhomboid major, rhomboid minor, and here we can see one of our supraclavicular branches, which is the dorsal scapular nerve. Okay, dorsal scapular nerve is traveling with dorsal scapular artery, servicing levator scapulae, rhomboid major, and rhomboid minor. So dorsal scapular nerve, dorsal scapular artery. Then, moving laterally, we can see our transverse scapular ligament. And then we see this artery and nerve pair by the transverse scapular ligament that has this relationship where the nerve goes under the artery goes over. So this is our suprascapular nerve and artery. And suprascapular nerve, we can clearly see is going to innervate the muscle in the supraspinous fossa, which is supraspinatus, and the muscle that's sitting in the infraspinous fossa, which is infraspinatus. So suprascapular nerve is responsible for supraspinatus and infraspinatus. Looking at this lateral view, we can see serratus anterior and the nerve that will be responsible for innervating serratus anterior, which is the long thoracic nerve. Okay, so another supraclavicular branch of brachial plexus. We have long thoracic nerve. And long thoracic nerve coming from C5, C6, C7. And lastly, our supraclavicular branch, that's not an extra image because it's quite straightforward, is nerve to subclavius, which is going to the subclavius muscle. Moving distally, we can now discuss the infraclavicular branches and talk about their responsibilities. So we already talked about or named the 5 terminal branches, and we said we could remember them by saying MARMU, which stands for musculocutaneous, axillary, radial, median, and ulnar. So let's start with those. And we can see that musculocutaneous comes from the lateral cord. Both axillary and radial come from the posterior cord. Now the median nerve gets contributions from both the medial and lateral cord. And then ulnar comes from the medial cord. So the cords, again, are named for their location relative to axillary artery. So lateral to the axillary artery, we have the lateral cord, which is going to give us the lateral pectoral nerve, which is responsible for, which we've already discussed, the innervation of pectoralis major. And this will also give us musculocutaneous. Okay, and musculocutaneous is going to be responsible for the anterior compartment of the arm. So biceps brachii, brachialis, coracobrachialis. From the medial cord then, medial to the axillary artery, we get medial pectoral nerve, right? And medial does more. So medial pectoral is going to innervate both pectoralis major and pectoralis minor. And then we get medial cutaneous nerves of the arm and forearm, and the ulnar nerve. Now, the ulnar nerve is going to innervate a couple of exceptions in the anterior forearm, because of course we always have exceptions to the rules. And it's also going to innervate muscles of the hand, but not all of them. So there's some exceptions going on there too, but we will discuss the exceptions as we move through the upper extremity, as we distally move through the upper extremity. And again, knowing the compartments is really, really beneficial and helpful. We then just have to learn the exceptions to the rules. Okay, so from the posterior cord, now we have upper subscapular, thoracodorsal, which is also called middle subscapular, and lower subscapular. So we already know thoracodorsal, right? Thoracodorsal nerve or middle subscapular is responsible for the innervation of latissimus dorsi. Now upper subscapular is going to do subscapularis, and lower subscapular will also do subscapularis, but it will innervate an additional muscle as well. So subscapularis as well as teres major. And then our terminal branches, we have axillary. We already know the axillary nerve. It's responsible for the innervation of deltoid and teres minor. And radial, which does posterior arm and posterior forearm. All the muscles in the posterior arm, all the muscles in the posterior forearm. And then our median nerve here comes with some more exceptions, but it's the exceptions that's shared with the ulnar nerve. So the median nerve is going to be responsible for the majority of the anterior forearm and some muscles in the hand. So again, we will look at that quickly, but we'll discuss it further in detail as we move through the upper extremity. Now let's focus on some of these terminal branches. And we know that axillary and radial come from the posterior cord. And the posterior cord was formed by all the posterior divisions coming together. So for now, we're just going to take all of that away and focus on what the anterior divisions gave us. Okay, so we have the lateral cord and the medial cord. And one of our terminal branches from the lateral cord was musculocutaneous. So we'll just say MC for musculocutaneous. And then when we talked about the median nerve, we said it gets contributions from the lateral cord and the medial cord. So here we can see our lateral cord and our medial cord giving contributions to form the median nerve. And then also coming from the medial cord was ulnar. So here we can see our ulnar nerve. And this is really a fun, awesome thing to see in the cadaveric specimen. So because of the contributions from the lateral and medial cord to form the median nerve, we get this characteristic M shape, which is musculocutaneous, median, and ulnar. So when we're in the lab, when we're looking, musculocutaneous is very easy to find because it's going to be diving into coracobrachialis. So as soon as you see a nerve going right into coracobrachialis, you know it's musculocutaneous. So you can trace it proximally towards the lateral cord and start then moving back distally, find the contribution, and then we see this beautiful, hopefully there's variation in the brachial plexus, but hopefully we see this nice, beautiful M-shape structure, which is 3 of the terminal branches that are coming from the anterior portion of the brachial plexus. So musculocutaneous, median, and ulnar. So now let's review those innervations. Okay, so musculocutaneous, we can see going right into coracobrachialis. And musculocutaneous is responsible for the anterior compartment of the arm. So musculocutaneous, biceps brachii, and brachialis. Now median, we said, has some exceptions. So median does majority of the anterior forearm. So instead of trying to focus on all of that, let's focus on the exceptions. So what muscle is not listed here? So we seem to be missing flexor carpi ulnaris. So flexor carpi ulnaris. And we see it's only doing the lateral portion of flexor digitorum profundus. So medial half and flexor digitorum profundus. Okay, so these are the exceptions in the anterior forearm, and they are going to be done by the ulnar nerve. And again, we'll discuss this more as we move through the extremity, but it's always good to start going through it earlier. The earlier the better. Repetition is key. Okay, moving into the hand then. We said that ulnar does some of the muscles in the hand, but on the picture we can see that median is also doing some of the muscles of the hand. So median is responsible for the thenar muscles, okay, the muscles that make up this fleshy part at the base of the thumb here, and 2 of the 4 lumbricals, okay, and the lateral 2 lumbricals. Okay, and then the rest of the hand is done by ulnar, which again, we will look at once we get there. Now here we can see the ulnar nerve, which we know does flexor carpi ulnaris within the anterior forearm, because that was one of the exceptions for median, and the medial half of flexor digitorum profundus. But now let's focus on the posterior. Okay, so we had the posterior divisions merged to form the posterior cord, which then gave us the axillary and radial nerve as terminal branches. So axillary, we can see right here, and axillary is coming out this space, right, our quadrangular space, and it's traveling through the quadrangular space with posterior circumflex humeral artery. Okay, and axillary, again, does deltoid and teres minor. Then we have our final terminal branch, which is the radial nerve, which again, the radial nerve is going to be responsible for the posterior arm and the posterior forearm. Okay, so instead of memorizing all of these muscles and saying radial after all of them, we just know that radial nerve is responsible for posterior arm and posterior forearm. When in doubt, draw it out. So very briefly, I will show you how to draw the skeleton of the brachial plexus and some of the supraclavicular nerves and infraclavicular nerves, and then you can go ahead and label everything and get good at drawing this. So then again, there's no need for memorization. And then we can trace the nerves back and see where they're coming from. Is this from the lateral cord? Is this from the medial cord? What ventral rami gave rise to this nerve, etc. So to draw brachial plexus in a very simplistic form, we can have 3 lines. And we have our roots, which we know C5, C6, C7, C8, and T1. Then we make Pac-Man with an X, and the same thing, but past the line. So now we can see our roots, our trunks, our divisions. So again, if we go like this to denote posterior divisions, we can see all the posterior divisions coming to form the posterior cord. So we have our cords and then our branches. So our cords, we have the lateral cord, posterior cord, and medial cord. Then of course our terminal branches, we have musculocutaneous, axillary, radial, median, and ulnar. So here we can see this nice M that we're going to be looking for in the lab when we do this dissection. We can see that axillary and radial are coming from the posterior cord. Posterior cord was formed from all 3 posterior divisions. Then we can go ahead and add our supraclavicular branches. So we have dorsal scapular, suprascapular, nerve to subclavius, and from C5, C6, and C7, we have long thoracic. Then from our lateral cord, we get lateral pectoral and musculocutaneous, also contribution to median. From the medial cord, we get our cutaneous branches, as well as our medial pectoral, ulnar, and contribution to median. Then from the posterior cord, we get upper subscapular, thoracodorsal, and lower subscapular. And there we have it. We can finish up today talking about why this is important. Why should we know the brachial plexus, right? Not just because it's incredibly cool, it's also clinically important. So things you might encounter in the future are brachial plexus injuries. So we'll start with upper brachial plexus injuries, which are more common. Okay, so Erb palsy can result from an increased angle between the shoulder and the neck. So if an individual is thrown from a motorcycle or a horse and lands on their shoulder, right, creating this separation between the shoulder and the neck, it can affect the superior trunk or the C5, C6 ventral rami, the roots. Right? Another possibility is increased stretching between the shoulder and the neck during delivery. So we can see, right, tearing of C5, C6 ventral rami. So if we know where the initial injury is, and we're saying, right, for example, C5, C6 ventral rami, let's think about some things that might be affected. What's something we know that comes from C5, C6? Let's just follow it, right? Superior root, okay, anterior division, then keep going, terminal branch, musculocutaneous, right? Well, musculocutaneous controls the anterior compartment of the arm. So let's just think about biceps brachii. What does it do, right? It flexes the arm, it flexes the forearm. It's also responsible for supination. So are we going to be able to do those things if we have damage to the upper brachial plexus or the superior trunk? Probably no. And what's another nerve we might see impacted? Suprascapular. Suprascapular nerves in charge of supraspinatus, infraspinatus. So, right, knowing what the brachial plexus looks like, we can, without going through the chart and seeing the presentation of these injuries, we can think about what they might be. Okay, so let's move over to lower brachial plexus injuries, or Klumpke-Palsky, which is less common than Erb palsy, but way this happens is from a very strong upward force on the upper extremity that's going to tear or damage the lower ventral rami. Okay, so we're talking about lower brachial plexus injury. So if somebody is falling, right, they're falling out of a tree or whatever the case may be, and they reach up to try to stop their fall, there's going to be this big jerk that can damage, right, the lower ventral rami, so C8T1. Another way is excessive pulling on the extremity, again, during delivery. So before we go to the presentation and talk about what we're going to see if this happens, let's think about something that comes from C8T1. If we follow our brachial plexus, we know how to draw it out. Right? What's a nerve that we're going to get? The ulnar nerve, right? And the ulnar nerve controls those muscles in the hand except for the exceptions that are done by median. All right, so let's look at the specific nerves that are affected, the muscles that are going to be affected, and what we might expect to see in somebody who has suffered either an upper or lower brachial plexus injury. Here we can see our different conditions due to brachial plexus injury. And now let's take it a step further and see muscles that might be affected and the presentation. So herb palsy, again, due to excessive separation between the shoulder and the neck. This is upper brachial plexus injury. So superior trunk, C5, C6, ventral rami. Okay, so in infants, lateral traction on the neck during delivery, so pulling this excessive stretch to injure C5, C6 ventral rami, or in adults, a trauma such as being thrown from a motorcycle or a horse, right? So C5, C6 nerve roots, we said something that is very obvious that's going to be affected is suprascapular nerve, which should be written in yellow, not red. Sorry about that. We'll add a yellow. Okay, so suprascapular nerve is responsible for innervation of supraspinatus and infraspinatus. So supraspinatus, what's it going to do? If the muscle contracts, it does abduction, abduction, right? From the supraspinous fossa to greater tubercle, contraction, abduction of the arm. But we're not going to have this innervation, right? We don't have the nerve to control supraspinatus. So our deficit is that there's no abduction of the arm. So presentation, we're going to see arm adducted, hanging by the side. Infraspinatus. Infraspinatus is responsible for lateral rotation of the arm. So we're not going to have lateral rotation of the arm. We're going to have medial rotation of the arm in this adducted, hanging by the side position. And right, musculocutaneous. So biceps brachii, coracobrachialis, brachialis, all innervated by musculocutaneous. If we think about biceps, biceps is responsible for flexion of the arm at the shoulder, flexion of the forearm at the elbow, and it's a very powerful supinator. So that's going to be our deficit. So now the arm is going to be extended and in a pronated position. Okay, so that is herb palsy. Then moving to lower brachial plexus injury, Klumpke-Polsky. Right, so affecting C8, T1, those inferior ventral rami. So again, an upward force on the extremity. So in an infant, this could occur during delivery, or in an adult, right, trying to stop a fall. We get this force that can cause damage to lower brachial plexus. And we said, when we think about brachial plexus, when we think about C8T1 and follow it over, right, this is going to be the ulnar nerve. Okay, so the ulnar nerve is responsible for innervating these intrinsic muscles of the hand, right? The thenar muscles are done by median, but let's think about the lumbricals, right, and the hypothenar muscles. So lumbricals are normally going to flex the metacarpal phalangeal joint and extend the interphalangeal joints. However, we're not going to have this. So this is the deficit, that's going to present with this claw-like presentation. Okay, so like a claw. And then the last thing we'll look at is a winged scapula. And winged scapula can happen to injury to long thoracic, right? Long thoracic is responsible for innervation of what? Serratus anterior. So this can happen during axillary node dissection when somebody is having a mastectomy, or also if we think about the position of the long thoracic nerve, when the arm is adducted, right, it serves as protection. It's kind of protected here. But when the arm is abducted, it's very vulnerable to injury. So if you take a knife wound to the lateral thoracic wall, or injury to the lateral thoracic wall can damage long thoracic nerve. So no long thoracic nerve, no innervation of serratus anterior. Okay, so serratus anterior is a protractor of the scapula, and it anchors the scapula onto the thoracic wall. So without this, right, the medial border of the scapula is going to shift lateral and posterior away from the thoracic wall. So let's look at injury to long thoracic on the following slide, and that will conclude the axilla and brachial plexus. Final slide to look at is paralysis of serratus anterior, again, due to injury of the long thoracic nerve, perhaps during axillary node dissection when a mastectomy is being done, or due to trauma such as a stab wound to the lateral thorax. So if we have an injury to long thoracic nerve, then there's no innervation to serratus anterior. And this is going to present with the medial border of the scapula moving in this lateral and posterior, like it's coming off the page, direction. So we can see this result sort of appearing like a wing. Okay, so this is a winged scapula due to injury to the long thoracic nerve. All right, so that wraps up everything for today. Thanks so much, and email me if you have any questions.